protein-sensitive hepatic encephalopathy. What is protein-sensitive hepatic encephalopathy? How do you know? Is there any indicators for that? I have never seen that in any textbooks. I would have to ask a physician if that's such a thing, but I don't, and even then, modest protein, well, what do they define as modest? There's no set number for them, although what I have seen is modest is 0.5, and then it increases. But even then, you would think that they would say something. But if you go to their regular big reference book, the manual that's in the back, it says, with patients with liver disease, they need at least 0.8 grams per kilogram of body weight, but the recommended amount to ensure positive nitrogen, or just to ensure nitrogen balance, is 1.2 to up to 1.5. And then it says most patients with cirrhosis, so now this is on the verge of these people with cirrhosis can go into hepatic encephalopathy, can tolerate up to 1.5 grams of protein per kilogram of body weight a day. And it says protein restriction should be avoided, and branched chain enriched formulas should be used only when the patient with severe encephalopathy fails to tolerate adequate amounts of standard protein. So, I liked that answer a little better. I thought it was weird that they didn't have them matching. So in the future, what are we going to see? Genetic engineering, I think, and technology will help us to have an alternative source of hepatic tissue and to test various intermediate metabolites, so we may have a better idea of how malnourished our patients are. And I think that they really need to try and specify different guidelines for the different stages of liver disease, and based on the different kinds, whether it's cholestatic liver disease or cirrhosis or fulminant hepatic failure, who knows. I think that there needs to be different guidelines because they may respond differently. I think that's pretty much it. Do we have any questions for me so far?
You know what, the first research you said, there you said that the research, the outcome of the low protein diet and the normal protein was same, but then again at the same time you said that protein breakdown with the low protein diet was worse. So then like that will be a concern, because if you're having more breakdown of protein, that means you're losing more muscle mass.
Right. Well, it was just it was not significantly different in the effects of encephalopathy, but it was different in as far as protein breakdown was happening more rapidly in the patients who had low protein.
Your total nutrition was
right. So that first study was looking at it from two ways. They were looking at it as the effects on encephalopathy at first, and then the effects of the actual nutrition protein reserves. Any other questions, comments, concerns?
I just thought it was interesting when you said that they did the study and they were giving them higher protein, and then with the mental exercises that they weren't having the confusion. I wonder, did they check their ammonia level? Was it fairly normal, or was it way out of whack that still showed that they are not mentally confused on these high protein diets?
They were checking ammonia levels on that, and they were also checking bowel movements. I don't know why that has to do with it, but there was a significant decrease in blood ammonia in the groups that were getting.
So when they space out the diet into the 3 meals and a snack, and also using the
1.2,
the other protein.
Oh right, the
casein
and vegetable.
Right.
Yeah.
So they need to do another study comparing if they eat meat to see
Right.
how if that will have the same effect.
Wouldn't that be cool? Okay,
Yeah,
who wants to do it?
We used to have this hepatic formula. We don't even have it anymore.
Huh.
Yeah.
For the tube feeding?
Yeah.
So most doctors here, what have you guys noticed? Do they do a lot of more low protein or moderate, or what have you come across?
Moderate. 1.2 to 1.2.
Okay.
1.2.
That's good. That's good.
But that's the concern on sometimes, because what happened that even though like we have to go by doctor's prescription, but they do that restriction, but given the disease process, lot of patients, they end up not eating adequately, and that's why say for example we like just not with hepatic patients, even with renal patients, say for example they are sending that 60 grams protein or restriction, okay. So, like even they call the menu, we send them that 60 grams protein, and then, when we restrict like that, maybe, we are not going to send them milk, or we are going to send them like a tiny piece of chicken or whatever, But then, when by the time they eat, my concern always remains that, what happens, that they end up eating maybe only 30 grams of protein instead of 60.
Right.
And that's why, I wish, MDs would let dietitian do more of it to say that,
Yeah, we would normally send them some supplements.
Yeah, good.
At least half of them.
So in the study, did they eat 100%?
That's a good question. The ones that were being tube fed, of course they did, because they had to.
Right.
Some of the others, I'm not really sure how well they measured that, and that's something that's hard, because even if you're getting somebody's opinion, like I had 30% of that or 70% of that, you break that down, there's still room for error there.
Right.
So, but the ones that were all tube fed or were on whatever very strict observation definitely probably were more accurate. That is a hard thing to do. These are the hard things about research in hospitals and trying to figure out all these things.
This has changed over years than what we did in our textbook.
Yeah, previously in the past it used to be a lot more restricted, right?
Very strict.
Yeah.
I got yelled at by a doctor.
You did?
He called me and said, "Why are you giving this patient a supplement on top of the diet that they already have?" And I said, "Well, first of all, the patient's barely eating." And I said, "And second of all, I said, if they're barely eating and they are taking at least, the amount of calories,
Right, exactly.
at least they're getting something." And he goes, "I want it off now." So I had to take the supplement off,
Wow.
and the patient didn't eat, and
No, you put the
who knows what
reference.
happened.
You print it out from the manual and put it there.
Yeah.
Yeah, well, that was within like the first couple of months of
I
me
had that problem
starting,
too.
so.
I took the reference with me and put it in the charge sheet of the doctor, and he okayed it.
Good, Bina, that's awesome.
Well,
No, that's good to know
future
because
reference.
Exactly.
Yeah.
And I'll leave these studies here for you, and you have your fun little sheet that we just recapped. And so, feel like now that you have, you got science behind you, so be empowered, because some of the doctors don't know that. And like the things that you guys brought up are good points. Like the doctor may say, well, they're on this diet, they're going to get everything they need, but then you realize, hey, look, this person's really only eating 10% anyway. So sometimes it's just like communicating with your team about that. They just don't know. They don't see that side, So, anyways, thank you.
Great.
Thank
Thank you,
you.
Kristin. Yay!